So I chose this topic because it's something that I actually have messed up before by not using PoCUS. Unfortunately, there were no adverse outcomes, but I think PoCUS could have really helped me. So that's why I went looking for an article related to it. So I was going to start with an elevator pitch about MSK PoCUS, and I'll do it for Marianne because I think everybody else is kind of bought in. So if there was a greater group here, I was going to say, three things that I thought were important about MSK PoCUS that maybe I could get you bought in by the end of this presentation. So one, I think it can change your diagnostic accuracy for some applications and potentially get better patient buy-in because they can see what you're doing. Two, it's relatively easy because if I can do it, anybody can do it. And three, it can have a significant effect on patient morbidity. It may not affect their mortality per se, but in some applications, it can affect their morbidity. So just hoping to get some more people bought in, but maybe this will help for Marianne. So I actually was inspired by Paul's talk about the 5.5 innovations about the half. And on my last talk for rounds, I kind of went through the patient story, and I think I was working more on the sympathy talk side of things, and now I'm going to take that one step further to the empathy side of things. So I want you to pretend actually that you're a family member of the patient for this one, and I just want this case to kind of set the scene. We'll quickly go through it, and then we'll get to the article. So the bubble's open, and you get to go to PEI with your family, and you are the mother or father or grandparent, however this applies to you, to this child, and you're playing outside, you're spinning them around and they scream out and you drop them on the ground by accident. The child doesn't hit their head or lose consciousness or anything, but they stand up and they're holding their arm and crying and saying it hurts. And, depending on what type of person you are, you either think their elbow's dislocated and it's going to be the end of the world, or maybe you think they just need to walk it off. Healthcare professionals have a different approach depending on your personality type. But in the end, you decide you can't be objective and you take your daughter, niece, etc., to the emergency department locally to be assessed. They receive some analgesia and triage, doesn't make much of a difference. They're assessed by the emergency physician there or the NP, and they are localizing their pain to their elbow. There's no significant swelling, the skin's closed, but they won't range it for you. They're holding it, mostly extended and pronated, and they're distally neurovascularly intact. There doesn't appear to be any other injury. So the physician, that's not you, it's gonna be hard to get my mind around that, attempts a reduction, assuming that this is a pulled elbow. About 20 to 30 minutes later, the child is still not moving their arm appropriately, still appears to be in pain. So they order an x-ray, and lo and behold, there appears to be a type 1 supracondylar fracture. And now you're not the physician, you're the family member, and you have this look on your face. And the first things that go through your mind are probably one, shoot, I was the reason this happened. Two, was the clinician thorough enough? Did they consider alternative diagnoses? And then three, you put yourself in their position and say, most of these are pulled elbows, the story fit, the exam fit. So did they really do anything wrong? And you think, well, we can't x-ray everything. That's time consuming. It extends the length of stay in the emergency department. It's expensive. And is it really necessary? And most times with a diagnosis of pulled elbow, it's not necessary. So you think, well, what about if I had x-ray vision or sonographic vision? And you do. So I just want to go backtrack a little bit now with the case, and hopefully that helps you put yourself in the place of a family member of a patient, or a patient if it were an adult patient with another diagnosis. And I put a little historical tidbit in here for David because he likes those. So the eponym for this condition is called nursemaid's elbow, and it makes us think, well, where did this name come from? And I wondered who these nursemaids were that hurt all these little children, really. So the nursemaid historically was the kind of apprentice or helper of the nannies, and they would be used in homes with, big families, a lot of children. And I guess traditionally they were younger women who were had shorter tempers and weren't as patient because they weren't as experienced. So they would pull on the arms of these children and cause this injury, apparently. So that's where the name comes from. I just wanted to refresh us a little bit on the anatomies, because that's very helpful, especially when we get to the ultrasounding part. So in the middle here, I'm just going to show you, this is the distal humerus. This is your medial epicondyle, lateral epicondyle. This is your proximal radius radial head. This is the annular ligament, and it articulates with the coronoid process of the distal humerus. On the other side, we have your trochlea and your capitellum of the ulna. And so that's to orient you. There's about apparently 13 different theories about what the pathophysiology of this condition is, and there's not agreement on this. What people do tend to agree upon is some tissue is interposed between the radial head and the capitellum. And the traditional thinking is that with a traction injury, that the annular ligament slips into that space. It's a very common presentation for children in the 1 to 5 year old age group. One of the most common presentations in the upper extremity. And the reason that we see it in that age group is because they have a little bit more lax joints, and the annular ligament is supposed to be more hypermobile. And as children get to be 6 and older, it's a bit thicker and stiffer, and so they're not as prone to this injury. So I was going to put in a little video. I wasn't sure if residents were going to be here, but I think I'll gloss over this. But this is just the two reduction techniques. So there's hyperpronation and the supination flexion, which I think everybody on this is aware of. And so the point of the case really was just to think about, if it looks like a duck and quacks like a duck, it's not always a duck. And a certain number of these cases won't be pulled elbows, even if they seem like that based on your story and your exam. And there's a big differential there. Most notably would be fracture. So the most common other diagnosis would be a type 1 supracondylar fracture with significant manipulation. You may turn that into another type of supracondylar fracture. In addition, there's intercondylar fractures, there's condyle fractures, radial head fractures, etc., as well as dislocation, ligament injury. And around the elbow, as we all know, there's a lot of real estate for nerves and vessels. And so if you were to displace something that was already somewhat unstable, you could get into causing a lot of harm with that. So it's just important to consider other diagnoses. So back to our sonographic vision. So this is the article that I chose. It's a diagnostic category article. It was published in the journal Injury just last month, actually. And it's called Two-Plane Point of Ultrasonography Helps in the Differential Diagnosis of Pulled Elbow. It's by Varga et al., and it was done in Hungary, actually, back in, there's about a year time frame between 2016 and 2017. It was a prospective cohort study, and they consecutively recruited individuals, what seems like. It was completed by 2 orthopedic surgeons, a orthopedic resident of I don't know what level who had adequate training in ultrasound, and the images were reviewed by radiologists who have training in MSK. And so basically what they did was they enrolled patients who were between the ages of 1 and 5 who presented to that center with the story of upper extremity trauma, who had the typical pain, decreased range of motion or motionless arm, who are holding their arm in extension or only slight flexion and pronated. And they excluded individuals who had atypical position. So if it was supinated and flexed, if there was a significant amount of swelling. So they didn't have a flow chart in the article, but just for me to help conceptualize their protocol, I made this little chart. So it's helpful for me. Hopefully it's helpful for you. So if they met, they weren't excluded, they met the inclusion criteria, they got to the point where they had a history and a physical, and then the patients were ultrasounded. So there's about 205 that were in that, made it that far. If they had we're going to talk about these specific signs and what they look like, et cetera, but if they had a posterior fat pad sign, that was indicative that there may be a fracture. So these patients went on to have an x-ray initially. If the x-ray was positive for a fracture or signs of an occult fracture, they went on to treatment, which included splinting and referral. If they had a posterior fat pad sign, but the x-ray was negative, they were splinted and they had a repeat assessment in the day 3 to 5 range. If at that point they had no tenderness and normal range of motion, they were just discharged. If at that point there was still clinical concern, they were put back into their splint and re-x-rayed at the 3-week mark. And at this point, they would look for signs of fracture, including callus. If they had a negative fat pad sign, so we weren't concerned with ultrasound that there was a fracture, and they made it through the inclusion and exclusion criteria, they were then had a trial of reduction through the typical techniques. A positive reduction was defined as so increased range of motion back to baseline and no pain, plus minus a palpable click with the reduction at 15, I believe, 15 to 20 minutes after the reduction maneuver, and they were discharged with the diagnosis of a pulled elbow. If they didn't have a positive reduction, then they were assumed that there was some kind of occult injury, and they had an x-ray at that time, splint plus minus re-x-ray like in the other arm. So I'm going to go through a little bit about the technique. I want to just put a little plug in here. Again, I wasn't sure if there was going to be residents on this or not, but any technique with children, you need to approach it with care, concern, and a plan. So use everything that you have available to you. If you have child life, bring them. If you don't, use your distraction techniques like bubbles and iPads, etc. Make sure there's appropriate analgesia. And it would depend on the child. You can ask the mom what type of child they think their child category their child falls into. So if they think that they would be interested in seeing this on ultrasound, then by all means get them interested, get them looking. If they think that it would be distressing or scary to them, then go down the distraction pathway. And I think mom knows best or parent knows best does apply here. I just put this little black box picture here because I think people get intimidated sometimes by MSK ultrasound because the anatomy is a bit intimidating. And I think the elbow is a little bit like a black box to some people. And admittedly, it was like that to me previously. Just like the heart is a black box, some people are the kidney traditionally. So I think if you find the anatomy intimidating, before you even step in the room, grab your ultrasound. Part of it is the positioning that messes you up because we label things medial and lateral based on the typical person standing with their arms, the palms facing forward. So take your arm, find your radius here all night at your wrist, trace them up, feel your radial head as you pronate, supinate, feel your olecranon, and just get oriented. And then if you're, it's the first few times you're trying this, pop the ultrasound on yourself before you go in the room just to get a quick look and orient yourself before you're doing it on the actual patient, just because we know that children are sometimes hit or miss whether they're going to be cooperative or if you're going to even get a good chance to get a good look. I did try this on my almost 2-year-old son who is very interested in the ultrasound, and it was difficult to get a good quick look, especially for the ventral view or the anterior view. So yeah, we'll see how it goes moving forward when I try to integrate this. So the first view that they did, they called it the longitudinal ventral plane examination. They used a high frequency linear probe. Again, this is orthopedic surgeons or an orthopedic surgeon trainee. I'm just calling it anterior longitudinal. I think that's more in line with the terminology that I use. So they basically are aiming right over the radiocapitellar joint. And these are the images that you would see. So starting on the healthy side, we have our radial head, proximal radius. We have our distal humerus or the capitellum. And then over top of it, we see tissue of the annular ligament. And this is what they're referring to as the synovial fringe. So that when we see that later on as a finding, that's what we're referring to. Here you can see the supinator muscle. So on the affected side, or the side with the diagnosis of pulled elbow, in previous studies, they've shown that these individuals may have an enlarged synovial fringe, as you can appreciate here, versus the other side. There are other findings that are documented in the literature but weren't included in the study, like an increased radiocapitellar distance or swelling of the supinator muscle, which I think I can appreciate in this image. But for this study that was looking at the two planes, the finding they were looking for on the anterior or ventral view was an enlarged synovial fringe. And then they had their second view as a longitudinal dorsal plane examination or posterior examination. Again, so longitudinal placement midline posteriorly. And then this is the view that they're getting here. I put this little image here in the bottom. I think it is helpful to remember that the fat pad is an intra-articular extrasynovial structure. So it will lift if there's an intra-articular effusion or fracture in this case. And for x-rays, it actually takes almost 10 mils to see this sign, so the elevated fat pad sign, but for ultrasound, it's as little as 1 to 3 mils of fluid or blood to see it elevated, so it's a bit more sensitive, which is in this pictogram here, much better, honestly, than the ultrasound. These are the ultrasound findings that they included in their study, so we're going to start with the normal side. So you can see this is your distal humerus. This is your olecranon fossa. This is your triceps tendon. And you can see the fat pad sitting nicely in here. And you can appreciate that the triceps tendon is nice and flat. This is the affected side. And for the positive finding here is for intra-articular fracture. So this would be negative in pulled elbow. That's what they're suggesting. So you can appreciate that the fat pad is elevated and there's some fluid down here. The fluid for this finding can appear a little more gray than you would expect, than anechoic fluid like you'd expect. And that's partially because there can be a lipohemarthrosis. You can actually see some layering apparently. And then here you can appreciate that the triceps tendon is kind of bowed out. So that is a finding that you would see if you were screening for a fracture, intra-articular fracture. So they performed, so an orthopedic surgeon or orthopedic surgery resident with adequate training performed those two views on all the patients that were included in the study. When they went through their protocol, 96% of the patients met the criteria for a diagnosis of a pulled elbow. 4% met the criteria for a fracture, so that includes occult and obvious fractures. 76% had a synovial fringe enlargement. That's overall. 80% of the pulled elbow group had a synovial fringe enlargement. And the fat pad sign was negative in all of the pulled elbow cases except for one. I put a little asterisk here, and in their discussion, they alluded to that they felt that the timing of the ultrasound may affect this finding, and that most of their cases were ultrasounded in the 2 to 6 hour from presentation timeline. And they felt that if patients waited longer, there is a higher possibility they may have a fat pad sign. There were 2 occult fractures. They had a positive fat pad sign and a negative synovial fringe enlargement on their original ultrasound. They then did the Cohen's kappa coefficient to look at their inter-rater reliability or agreement between the radiologist who was blinded and looked at the recorded studies and the orthopedic surgeons or orthopedic surgery resident. And they found that the agreement was good for synovial fringe enlargement. Now, apparently they didn't include the numbers for this, but in their discussion, again, they mentioned that it was not as reliable for the ventral view, and it was excellent for the fat pad sign. So again, I just made a little table that was a little bit easier to see than what they had presented. Oh, sorry. And they looked at sensitivity, specificity, positive and negative predictive values. So the synovial fringe enlargement, so the specific finding for pulled elbow was okay sensitivity, great specificity, not a great negative predictive value, as you'd expect. The fat pad sign performed well all around. Again, this was looking specifically for fracture, which that is in line with what's been seen with previous studies, and combined their 100% sensitivity, specificity, predictive values. So combined, this is their argument that you can basically negate the need for an X-ray if you combine these findings. So there's some limitations to the study. It's small, 200 patients, single center. It was conducted by specialists, and we don't exactly know what kind of training they had in this area. The anterior, or what they call the ventral view, they alluded to in their actual study that the inter-rater reliability was different. It was a more difficult view to obtain. And I can say, just trying this, I can see that. The positioning has to be right, and if you slide a little bit one way or the other, you may get a different view. They also didn't define what a large synovial fringe was. It sounds like it was just an eyeball method. The rates, they said, compared to other studies, were a little bit less. So why that is, they didn't actually know. The timing of assessment, again, they were all seen within 2 to 6 hours. The latest couple, I think, were out till 12 hours. But they said, you may not be able to apply their findings if the assessment was a bit later or even very, very early. And then the other thing was that synovial fringe enlargement can actually be a normal variant for patients that have hypermobility or hypermobile joints. But you would, if you were looking at both sides, which you should, be able to see that that was normal for them. So just a little bit of a critical appraisal, I guess. Are the results of the study valid? I think that they used appropriate inclusion and exclusion criteria. I think they defined things well. I think that it would be reproducible if we had maybe a little bit more information about the training and what they called synovial fringe enlargement. But I think overall, the results are valid. Are they applicable? I don't know that I can say that their results are applicable to me in the emergency department, because I think that their expertise was different. I think we need to define what appropriate training would be for this, and like most things in PoCUS. And I think that they would need to further define how we define what synovial fringe enlargement is, and if eyeball technique is even appropriate. So how would I apply this to my practice? So I think like before, any suspicion or on history or physical for another something on the differential, I'm going to be doing an X-ray. If I'm going to think about doing a trowel reduction without an X-ray because my Bayesian approach is leading me down the path of this is definitely a pulled elbow, then I'm going to put the ultrasound on. If I see a positive fat pad sign, I'm going to stop, not do the reduction, and I'm going to get an X-ray. I'm going to start looking for the synovial fringe enlargement and try to develop that skill. And if I saw a negative fat pad sign, I would do the reduction like I had said before. So that's kind of how I'm going to apply this to my practice right now. For further study, I think there's a lot that could be done with this. I'd like to see what the definition of synovial fringe enlargement is, if that can be reliably defined by an eyeball method versus measuring compared to the contralateral side. I'd like to see a study with emergency department docs, of course, just to see if in our hands, if it's as reliable and accurate as it is in the hands of a orthopedic surgeon or resident, and in the eyes of an orthopedic surgeon or a radiologist. I'd like to see, does this affect patient-centered outcomes? So did it improve pain, or will it improve pain, function, And what did it change the ED length of stay? Does it change X-ray use to be used more, to be used less, to be used appropriately? And does it have an effect on cost? And they did mention in their study that you can use it to confirm your reduction attempt by looking at the disappearance of the enlarged synovial fringe, but they never included that in their study results. So I think that's another area that would be helpful. So that was related to the elevator pitch, which we'll skip over. Those are my references, and happy for any questions.